why don't we get started in the interest of everybody's time and just acknowledge that will be people that will be joining us as we roll on. So good afternoon, everybody. Janice LaBelle from DMH Central Office, Child, Youth, and Family Division. Welcome to DMH's ongoing effort at restraint and seclusion prevention through a steady stream of informed education in different aspects of our work that really help to create a trauma-grounded service in those that we work with. I am so pleased to be able to introduce Dr. Janina Fisher. We just took a little mini stroll down memory lane before everybody logged on and figured it's somewhere in the order of 16 years that she has been consulting, educating, teaching, training, and helping us get solidly grounded in a platform of trauma-informed work, recognizing that we work in different settings, we work with different populations, but as long as we have a touch with working with people who have been wounded, this work is so relevant and important, and there is nobody better than Janina Fisher. There, I said it, and it's absolutely true. She is hands down the penultimate favorite of all of our presenters, and she is a gift to Massachusetts. So I am honored to and really just welcome Dr. Janina Fisher, thank her for her continual contribution and always saying yes when we ask her to present. We would appreciate it if people have ideas, thoughts, aspects of trauma you would like to learn more about. Please drop suggestions into the chat. We really want to make sure that we've got ongoing relevance and responsiveness to the work that you're doing and where you see the gaps. Because as a number of our colleagues have surmised, we're all starting over. We've had a big jolt a la COVID. We've had significant workforce turnover, and we are starting back fresh and really looking to learn together again. So with that, thank you, Dr. Fisher, and welcome everybody.
Thank you. Thank you, Janice. I just want to add, as many of you as you can, turn on your cameras, because it's much harder to talk to little black boxes than to real people, right? Zoom is challenging enough, but it's nice to see who's really there. So I want to add to what Janice just said, because it's true, we don't know the particular, we know the clients, obviously, but we don't always know the particular challenges that you all are facing. And that's why we're here, to help you through those challenges, because as it turns out, the statistics are that most of our most difficult clients are clients with trauma histories, regardless of diagnosis. And so this material is relevant across many, many diagnoses. So I wanted to share with you the benefits that can accrue to us if we bring more mindfulness-based techniques even into our conversations with clients. The more we help them to notice rather than react. That's really the heart and soul of it. As you know, DBT teaches mindfulness, but it's very hard for our clients to take away the how to use mindfulness from a few groups. It just doesn't seem to take as well as we might like. So here are the characteristics we usually see in our most challenging clients. They have histories of abuse, neglect, foster care, homelessness, instability of all kinds. Usually their trip through the mental health system has begun by age 13, usually in the context of cutting. In many, many cases, the only stability these clients have ever known has been in ERs, hospitals, and clinics. And their only safe attachment figures have been mental health professionals, which of course means that they are going to have very strong attachments to us both ways, both positively and negatively. Multiple diagnoses, the number of diagnoses that correlate with a history of trauma grows by the day. But all of the diagnoses you see here have been associated with histories of trauma. We know that our traumatized clients are less likely to benefit from the usual traditional treatments. And we know that they, unfortunately, they don't mean to, but they take a toll on staff, because often these are the clients who exhaust us and make us start thinking about other careers, right? I remember in my first job, I worked in a program for what we would now call children on the spectrum. And I remember the conversations the other staff and I would have at lunch would be, what if we went into publishing? Right? There must be a better field than the field we're in right now. So let's talk about, how could it be that across diagnoses, including, I didn't even put schizophrenia here, because there's now a whole host of studies that show an association between a diagnosis of schizophrenia and a history of trauma. So that should be in that list too. So let's talk about trauma and the brain, because obviously, if trauma affects people with markedly different diagnoses or causes markedly different diagnoses, that's because of its effect on the brain. So this is a simple, outmoded model of the brain, but I like it and trauma therapists like it because it simplifies the brain into only 3 parts. And the brain has hundreds of structures. So 3 is about all I can manage. The most primitive is what is called the reptilian brain. That's the brain stem, the very back of the brain, which controls our instinctive responses, basic functions like heart rate and breathing, impulses, very, very important. The emotional brain or limbic system is this middle region of the brain. That part of the brain is responsible for our emotions, emotional memory, responses to threat, and also somatosensory and relational experience, all the things people come for help with. The problem is the reptilian brain is a nonverbal part of the brain, so is the limbic system. And then we have the prefrontal cortex, which is finally a brain with words, with language, capable of being analytical, logical, sequential. It gives us a memory for what's good judgment and what's bad judgment. It gives us the ability to learn from experience. And most importantly, the prefrontal cortex is the part of the brain that can say, whoa, don't do that. That's a bad idea. The problem is that when we are threatened, whether we're threatened once, as in, a mugging, or we are threatened every single day, as in child abuse, domestic violence, war. That threat cue, those threat cues are registered by the limbic system. So they're registered in the nonverbal part of the brain, this little structure called the amygdala, which is the brain's smoke detector and fire alarm. The amygdala picks up that threat signal and it sounds the alarm, putting into place a series of biochemical changes that allow the reptilian brain to act and react. And very importantly, the thinking brain shuts down. Study after study has seen this phenomenon in traumatized individuals. It's one of the most consistent findings about trauma. So when our clients get activated, they lose the ability to think. That's a problem because we're trying to teach them to think before they act, and they've lost access to the part of the brain that can think. Now, the result of living in a dangerous environment, and let's face it, most types of trauma are dangerous environment based. Right? We rarely see people with a single one event trauma. It's very, very rare. So most of the time, our clients come to us with symptoms consistent with a traumatized nervous system. And therein lies the central problem in these disorders. So this is a very simple model of autonomic arousal. Those of you who've heard me speak have heard me talk about it many times, I'm sure. We all have nervous systems capable of very high arousal, right? High arousal allows you to run like a bat out of hell. It allows a parent. I remember my daughter-in-law, who's probably 100 pounds and barely 5 feet tall, managed to stop a revolving door and pull it open because her 2-year-old daughter got trapped in the revolving door, right? That's hyperarousal. It gives us the strength of Superman. We also have a nervous system capable of very, very low arousal, which is what you see in hypothermia or a medically induced coma, where the body's energy becomes, they call it energy conserving. All of our systems slow down so that all of our energy, little as it is, can go into simply surviving. So in hypoarousal, what we see is a loss of energy and a kind of just existing day to day. Great if you're a prisoner of war, that's what you want. Often for victims of domestic violence or children who are abused, that state helps them to last until they can leave home. But when those states are stimulated every single day by the dangers, and remember, if we're in danger, we don't react just when something happens. We're constantly reacting to the anticipation that something will happen. So what we see is when our clients are either in very high arousal or very low arousal, the prefrontal cortex shuts down. And here are the kinds of symptoms that we're likely to see. Clients who have a hyperarousal pattern, perhaps because they had to live on guard, ready to run, ready to hide, ready to react. So hyperarousal is the cause of impulsivity, or I should say impulses and impulsivity. It drives risk-taking. You can't have good judgment if your frontal lobes are shut down. So judgment, contracts, safety plans, all out the window, not because the client has thrown them out the window, but because the part of the brain that remembers the contract is offline. Hyperarousal is consistent with all kinds of anxiety, from generalized anxiety to panic and terror, to racing thoughts, to what I call post-traumatic paranoia, which often gets misdiagnosed as delusional. It's the fear of something happening that is already happening. So the client says, somebody's after me. Well, that was true when the client was a child scapegoated in an abusive family. So different from, I'm thinking back to an old client of mine who believed that she was being stalked by the IRA, and they had an assassination plot, right? That was delusional paranoia. It wasn't post-traumatic paranoia. Flashbacks and nightmares are caused by hyperarousal. Difficulty managing anger is hyperarousal, and all self-destructive behavior and much of the addictive behavior we see, all is driven by high arousal. And hypoarousal tends to drive treatment-resistant depressions because the hypoarousal leads to a kind of numbing, a flatness, slowed cognitive processing, slowed everything. Hyperarousal seems to generate anxiety and anger. Hypoarousal generates shame and depression. And so often these hypoarousal clients are very passive. They have trouble with ADLs. They get used and abused by others because they are too passive to be able to defend themselves. Now, let's look at the hyperarousal related diagnoses. Borderline personality disorder, also narcissistic personality disorder. The whole realm of suicidal and self-destructive behaviors, the whole realm of addictive disorders, anxiety disorders, and hyperarousal is also associated with hearing voices. We have to remember that voices are not only a symptom of psychotic disorders, they're also a symptom of trauma-related disorders. And there's research showing elevated levels of voice hearing in combat veterans, in clients with borderline personality disorder diagnoses. Very, very important that we not assume that voices mean psychosis in our traumatized clients. And then, of course, Um, hypoarousal is consistent with a diagnosis of major depression. I think often clients get misdiagnosed as major depression because the symptoms of hypoarousal are so similar to the symptoms of depression. And because some traumatized clients have both hyper and hypoarousal symptoms, they often get diagnosed bipolar 2, even though their highs and lows are usually trigger related and happen many times a day. So, and in bipolar 2, many times a day doesn't count as a symptom. Now, whatever the diagnosis, the one thing we have to start by doing is reactivating the prefrontal cortex, because there's no treatment that anyone has invented on this planet that will work with somebody whose prefrontal cortex is offline. DBT, you need to be able to think, learn, and remember. Same with CBT. Same with psychodynamic psychotherapy. I could go on and on. EMDR. You need a prefrontal cortex to have a good response to treatment. And Joseph Ledoux explains why. He says, in order for the amygdala to respond to fear reactions, the prefrontal region has to be shut down. Very interesting. Keep that prefrontal cortex online, and the amygdala cannot freak out. Pathologic fear, then, may occur when the amygdala is unchecked by the prefrontal cortex. And treatment of pathologic fear may require that the patient learn to increase activity in the prefrontal region so that the amygdala is less free to express fear. That means if we can keep the prefrontal cortex activated, we're going to see fewer crises in our clients. We're going to see less impulsive behavior. We're going to see more affect tolerance, more ability to collaborate with treaters, all the things that we wish we could see in some of our more challenging clients. And mindfulness-based techniques have many advantages. First of all, they're easy. So our very challenging clients can be successful using them. They also calm the body, and as well as stimulate activity in the prefrontal cortex. And that's very, very important. And the other thing that's important, as Dan Siegel says, is that where attention goes, neural firing goes. And where neurons fire, new connections can be made. And we want our clients to make new connections because their pattern of old connections is not working for them. That's why they're in our programs. So here, I'm going to move our faces here down to the bottom. So now, in therapy, here's the amygdala, the major source of difficulty that leads individuals to seek help, right? Because the amygdala contains, right, it has the early warning system. So it's very sensitized to threat. I think 2/3 of its cells are devoted to scanning for threat. And it also has the job of sounding the alarm, thereby activating all of the intense and or non-intense trauma-related reactions. And remember, the amygdala is a non-verbal part of the brain. So here we are, we have the client whose amygdala is kind of a mess. And we use the left brain to talk about, with the client, to talk about their distressing emotions, their coping skills, their safety plans. And often we try to make a connection to the past, so that the client has an understanding of what is happening, other than the usual habitual understandings, which tend to be, I'm worthless and I might as well be dead. Now, oops, why am I? Sorry, I'm having trouble moving the slide here. Hang on, I have to move our little boxes again. Whoops. Okay, there we go. There. Come on, you can do it. Okay. The left brain is devoted. We have many functions in the left brain. All the things we learned in school, multiplication tables, spelling, right? The left brain is like a whole storage unit of information. We have our autobiographical memory, the memories we have of our lives. We have information. We have information we learned in elementary school, high school, college, in the workplace. And we have what's called working memory, which allows us to take many different ideas and sift them together to create a concept or a plan. So this part of the brain, the working memory part of the brain, is called the dorsolateral prefrontal cortex. And the problem is that it has no connection to the amygdala. We can talk all day long about why people are feeling the way they do. We can talk all day long about safety plans and coping plans, but without a direct connection to the amygdala, those plans are ways of managing the amygdala, not calming it. So now, mindfulness gives us another option, right? We still have the amygdala, the source of all of our problems, unfortunately. We have the dorsolateral prefrontal cortex. Now, we have one other option in the brain, which is the medial prefrontal cortex, the middle part of your prefrontal cortex, because that does have a direct connection to the amygdala. And we actually have research that shows that when the medial prefrontal cortex is activated, the amygdala reduces activity, right? Just as Joseph Ledoux said, the more activity up here, the less activity in the amygdala. And again, regardless of diagnosis, we want to help clients to calm their amygdalas, because because that is so much the source of the difficulties they face. And it's wonderful to think that you can help people calm and access their thinking brains simply by using mindfulness techniques to activate the medial prefrontal cortex. And there are lots of studies that show that there are brain scan studies of meditators that show that when meditators meditate, the part of the brain that gets active is the medial prefrontal cortex. So a very, very important, I was going to say weapon. That sounds a little too violent. Let's go for tool. So what do we mean by mindfulness? Mindfulness has a number of ingredients. We can use all of them or some of them. I actually recommend teaching clients one at a time, because when your prefrontal cortex is offline, it's very hard to take in a lot of information. So the first ingredient of mindfulness is recognition, observation, awareness of thoughts, feelings, impulses, sensations, what's going on around us, noticing rather than reacting. Another ingredient is noticing that feeling, thought, reaction without getting swept away by it. It's a very little detachment. I've had many clients who said, but detachment, that's part of my problem. Right? And I said, well, this is a different kind of detachment. It's not detachment where you don't feel anything. This is detachment where you feel the feeling, but you notice it. You have a relationship to it. And you can see each of these is a different learning experience. Labeling, helping the client to put neutral language to what they notice. So if the client says, I'm a worthless piece of you-know-what, or if the client says, I just wish I were dead, those are thoughts that stimulate feelings, right? And so in mindfulness, individuals are helped to put neutral language. I'm having the thought that I don't want to be here. I'm having the thought that I'm worthless. I'm noticing a feeling of anxiety, right? That's a very different experience than I'm anxious. I'm so anxious. I'm jumping out of my skin. I'm so anxious, which creates a vicious circle, because the more the client says, I'm anxious, I'm really anxious, the more anxious the client will feel. And I demonstrate that all the time, because I'm not an anxious person. And so, but if I say, I'm anxious, I'm really anxious, I can feel my heart rate increasing. So the words we say to ourselves have an impact. Mindfulness helps us to notice that impact. And mindfulness can be open-ended or directionless, or it can be focused. So we can help people to notice all the different thoughts, feelings, and sensations and impulses that come up. or we can ask them to focus on one element. So, which is something DBT takes advantage of, because they ask clients to direct their attention to something distracting, right? That's a use of directed mindfulness. Well, I actually love some of the DBT handouts on mindfulness. The problem is, from this point of view, those handouts have so much information on them. I love that. But if you're a client whose prefrontal cortex is not working well, which with any of the diagnoses we're talking about, the prefrontal cortex is not working well. So those handouts, informative as they are too much to process. So I love to take the kind of the particular, I think, effective pieces of that very detailed handout. And I teach clients to have a Teflon mind, to notice the negative feeling or thought, and then to let that feeling kind of slide off. What we often talk about is roll off your back, but I never use that language because our clients have heard people, why can't you let it go? Why can't you let it roll off your back? And that's, those words now evoke anger or shame. Having a Teflon mind is a different idea that, again, is more neutral. The other, I think, useful idea from DBT is the idea that we have a logical mind, an emotional mind, and in the middle, we have to find our wise mind, which is really the medial prefrontal cortex. It's another way of saying the same thing. It's very easy to teach mindfulness skills to clients because of how simple they are. And the two words that evoke mindfulness with my clients are notice and be curious, right? So they're saying, I'm overwhelmed, I'm ready to give up. And I say, notice that feeling of wanting to give up. Let's be curious about that thought, I want to give up. Right? Just notice the reaction. Is it more physical or more emotional? Notice the sequence. If there's a crisis, I like to do a mindful analysis of it. So I say to the client, okay, let's roll back the tape to before the crisis started and notice what's happening. Okay, so what was happening was you were home alone, you were bored, and you were lonely. Okay, that sucks. Let's move to the next frame. So there you are, you're home alone, you're bored and lonely. What happens next? And the client says, I felt trapped. Okay, right. So let's go to the next frame. You were feeling that feeling of being trapped. And then what happened? And then the client says, I thought, I have to get out of here. This reminds me of an old client of mine who used to flee her apartment at 2, 3 o'clock in the morning because she would start to get scared. And she didn't think. Being a young woman running by yourself on city streets at 2 or 3 in the morning is more dangerous than being in your apartment and scared. But she was having a feeling flashback. Her mind and body were remembering her childhood experience that once night fell, she was in danger. So the other mindfulness skill is helping people to be curious about what triggered them. Now, that can be discouraging because I'm sure most, if not all of you, have asked clients what triggered you, and they say, I don't know. Standard answer, right? And you know why you get the answer? Not because they mean to be difficult, because their prefrontal cortex is shut down. So they can't think. They really don't know because the part of the brain that can think about your question is offline. So when the client says, I don't know, which is most of the time, I say, well, let's notice what was happening just before you got triggered. And again, we go frame by frame. Now, one of the problems, and I think this is a problem in DBT, mindfulness in work with clients depends upon the staff or therapist becoming more mindful. So that means that when we are helping clients to learn mindfulness skills, that we slow our pace, right? Because mindfulness is slow. Talking is fast, right? Interpreting or concluding or judging is fast, but refraining from interpretation and just noticing a thought, a feeling, a physical sensation, that's a slow pace. And if we don't slow it down, the client will slow it down, unless the client is in hypoarousal, in which case the client will be so slow that actually no thinking can take place. So slowing the pace, not too much, but enough to really help the client observe. It also, by the way, slowing the pace also helps with very intellectualized clients, because it's hard to stay intellectual at the slower pace. So I love to sort of to defeat the intellectualized clients by slowing things way down. The other characteristic of mindfulness is that it's present moment attention. Mindfulness doesn't care what happened an hour ago, 5 minutes ago, 20 years ago. Mindful attention is about this moment. So, but we can use mindfulness because all we have to do is to say, as you talk about what happened this afternoon, what's happening inside you now? Because, of course, when we talk about distressing things, we start to feel them again. And also, we helped clients to be more interested and curious. That can be a challenge, and it starts with our being interested and curious. So if we listen with a curious, mindful ear, if we don't, it's very easy to what's the right word? A lot of what our clients feel is very contagious. When they're anxious, we pick up their anxiety. When they're depressed and hopeless, we can feel ourselves starting to feel more hopeless. And so when we're curious, we're less likely to catch the feeling the client's having and more likely to encourage the client's curiosity. So if I'm hearing the client and I'm curious, I'm going to respond differently than I will respond if I think I know what's going on. And I have to communicate, I have to ooze curiosity in my voice and body language so that it's very hard not to catch it. Right? So let's be curious about when you say those words. I love this one. The client says, I'm gonna kill myself. I'm gonna die. I won't see you next week because I won't be here. And I say, okay, when you say those words, I won't be here, is that a thought, a feeling, or an impulse? Because that forces, that question forces the client into curiosity. Is it a thought? Is it a feeling? Is it an impulse? Let's say I'm thinking of a client of mine. She would say, it's a decision. Okay. And is that decision a thought, a feeling, or an impulse? And she actually, I have to say, she's gone from someone who was relentlessly suicidal on a daily basis, never actually made an attempt, wasn't hospitalized that much because she would contract at the very last minute, drove her therapist absolutely crazy. And now she might have a few days of suicidal ideation, maybe every 4 to 6 months, because she has learned to hear those suicidal thoughts with curiosity. And she's also learned to notice when she's feeling more hopeless. That's a cue for her suicidal part to start to say, oh, come with me. I have the exit plan. You just have to kill yourself on Monday and you'll be fine. And now she can hear that as not as a decision, not as an intense emotion and impulse. She can hear it as, oh, my suicidal part wants me to give up. We tend, all of us, to treat thoughts, feelings, body sensations, impulses as the same thing. When the client says, I feel hopeless, we think, oh, the client is hopeless. But actually, I feel hopeless could be a thought. A thought like I don't believe things will ever get better. When my client, Suzanne, the client I was just speaking about, when she actually looked at what the hopelessness believed it wasn't safe to hope because you'll be disappointed. So really the hopelessness was a cognition that would then trigger the physical impulse to give up and collapse. Very, very different, though, when she deconstructed, I feel hopeless, into its component parts. Most of the time, I feel hopeless is a belief based on feeling overwhelmed, feeling down, based on hypoarousal. And when I ask the client, is it a thought, a feeling, or a physical sensation? The client says, it's a physical sensation, or it's a thought. Same with, I'm suicidal. Is that a thought? Is that a feeling? Or is that an impulse? You know, suicidality is dangerous when it's an impulse. When it's a thought, it's just a thought. So it's actually a good way of assessing suicidality to ask this mindfulness question. So here are some non-mindful questions, which are the kinds of questions we often ask. They're perfectly good questions. So we might ask, have you always been angry at your mother, right? Client is going on and on about how angry they are at their mother. In mindfulness, we would say, can you feel that anger right now? Because that's really the important information. If the client's feeling the anger right now, there's something we can do about it. If the client has always been angry at their mother, there's really nothing we can. The past is the past. We can't change it. But we can change what's happening in this moment, right? We can't change the future either because it hasn't happened yet. But we can change the present moment when the client is worrying about the future. Okay? Very typical non-mindful question. Do you remember when you first started feeling so anxious? And the client might say, I've always felt anxious. A mindfulness question would be, what happens inside when you start feeling so anxious? The client's complaining about how difficult it is at work and how they want to quit. I would probably ask as a non-mindful question, what's been difficult at work? But a mindful question can get us even further. Just imagine being at work right now. What happens inside? What happens in your body? What happens inside you? I have to keep moving this little box. Right. I could ask as a non-mindfulness question, what makes you fearful? What's scaring you? In mindfulness, we would say, sense the fear. What do you notice when you say you're fearful? And what tells you that you're afraid? Is it your heart rate? Is it knots in the stomach? Because often when clients start to notice these details, it calms the body. So I can remember when I first started doing a lot of public speaking, I was understandably anxious. And I found if I said to myself, oh my God, I'm really anxious. Oh no. Okay. What if I don't know what I'm talking about? What if I got more and more anxious? when I just focused on my heart rate and just noticed it as a physical phenomenon, I felt less anxious. When a colleague of mine asked me, what tells you that you're afraid? I realized it was the thoughts that were stimulating the physical anxiety symptoms. And she said, well, excitement and anxiety are very similar. So maybe you're excited. And as soon as I noticed the same symptoms, and I said, oh, I'm excited. This is a new idea. I'm excited. Then I didn't have the anxious questions anymore. So helping people to notice the feel, like, how can you tell that you're angry? Now, we have to use language that is adjusted for a prefrontal cortex that is shut down, right? Because we ask questions that assume that the client can think and can, if they try, give us a meaningful answer, that they will answer honestly and fully. Again, you often can't answer honestly and fully if you can't think. So we have to avoid why questions. If we have clients who are acting out, a why question is not going to yield meaningful information, because the part of the brain, why questions are conceptual questions, right? Why did you do that? Is a conceptual question. We have to be able to put things together. We have to have a working memory, none of which is available when the client is activated, triggered, unable to think. The same is true with following directions or commands, right? As much as for safety reasons, especially in hospitals, the kind of standard is the client has to follow directions. The fact is that clients can't follow directions when the prefrontal cortex is inhibited, right? Because we can't process what we're being told to do. We can use noticing language. Just notice what's happening. See what happens if you take a breath. Right? Let's slow everything down. Notice what triggered you. Because again, directing attention, in some ways, it doesn't matter what triggered them now. But when I ask that question, notice what triggered you, I'm trying to help the client focus, because focusing will calm the nervous system. We can't expect clients to answer open-ended questions or complex questions either. And we have to remember, this is especially true in state hospitals. Often the clients have years and years of an inhibited prefrontal cortex that has been underused. And so when the autonomic arousal is high and the prefrontal cortex has a habit of underuse, clients feel stupid, they feel confused, Often they give us very vague answers rather than saying, I can't think, because we assume they can think, they assume they can think. And so what often happens is we get a vague answer or we get an answer that fits what the client thinks we want. And so, I see that especially around cutting, because so often clients, when asked why they cut, will say, I do it to punish myself. That's an answer that either they heard from a mental health professional or they believe that to be our expectation. Because cutting is done as a way to get relief. Therefore, it can't be a punishment, which is what I say to clients when they say, oh, I just do it to punish myself. I say, I don't understand. I'm confused. Because how could something that brings you so much relief be a way of punishing yourself? Ask multiple choice questions. You know, the beautiful thing about multiple choice questions, I don't appreciate them on tests, but there is a logic, because when we're asked a multiple choice question, it stimulates prefrontal activity. So I can ask multiple choice questions about what's going on right now. When this happened, were you more activated or more shut down? Did you know what was happening at the time, or were you surprised when it happened? Did it feel more like trying to die or more like a way of trying to get relief? Again, the multiple choice questions stimulate the prefrontal cortex. So, I mean, I remember at the old Westboro State Hospital, I remember doing this kind of mindful chain analysis of crises. And so often, to my amazement, the clients didn't know what was happening at the time. I remember a client who got put in restraints because you can see how far this goes back, because she was late for the smoking break. And when the nurse told her, you can't go, it's too late, she started to argue. And the next thing she knew, she was being put in restraints. And it was really very important learning for me to realize when the prefrontal cortex shuts down, clients lose awareness of their behavior, of its effect on other people, and on the consequences. Very, very, very important. So I love to use menu questions with clients because, especially, you know, the beautiful thing about these multiple choice or menu questions is that if you have a very hypo-aroused client, very shut down, very slow, you know, men and women of few words, and it feels like climbing a mountain just to get a little dialogue going. Ask these menu questions. When you feel the panic come up, what happens? Do you feel more tense, more jittery, or do you want to run? Right? Usually, when given a menu question, clients can either say, oh, I feel tense, or they say, not any of those, maybe more shaky, because having that menu stimulates the prefrontal cortex, and then they can come up with their own words. As you feel that anger, is it more like energy or muscle tension, or does it want to do something? One of the best ways to help people deal with anger that is unmanageable or inappropriate is to help them notice the anger as a physical sensation. Usually when I ask this question, 90% of people say, oh, the anger, it's a lot of energy. Okay, great. So notice the energy. Does the energy feel good or bad? And most of the time, I mean, sometimes people say, well, anger is bad. And I say, oh, I wasn't talking about the anger. Is the energy, does the energy feel good or bad? And then they say, oh, the energy feels good. Right, right. So when they feel the energy of the anger, it lessens the impulse to do something to discharge it. And I can teach clients to enjoy the energy and to hold on to it, because it feels empowering when they hold on to it, and it really it fights depression. Getting angry doesn't do the same thing. It's the feeling the energy of the anger that's empowering. Here's one of my favorites. When you talk about feeling nothing, what does nothing feel like? Because I'm sure you all feel the same way when you ask clients what they're feeling or how they're doing, and they say, I'm fine, or I feel nothing. It can be very frustrating, but I have a comeback. When you talk about feeling nothing, what does nothing feel like? When you talk about feeling fine, what does fine feel like? Is it more like calm? Is it more numbing? Is it kind of foggy? When clients say, I feel okay, I say, okay, as in, you wouldn't tell me if you weren't okay? or I've just had the best day possible. And most of the time they laugh and they say, oh, I wouldn't tell you if I didn't feel okay. And when clients can't even answer the mindfulness question, I mean, the menu questions, you can ask either or questions. Does that feeling feel good or bad? Is it more pleasurable or unpleasurable? Does the danger or the threat feel like something that will hurt you from the inside or the outside? Which, when I first heard it, I thought, that's a weird question. Does the danger feel like something that will hurt you from the inside or the outside? But then just a couple weeks later, a client of mine she came to therapy and she said, I'm feeling really unsafe today. I mean, unsafe, like something's going to hurt me. And I'm scared. And I said, does that feel like something that will hurt you from the inside or something that will hurt you from the outside? And she thought and she said, oh, it's coming from the inside. Okay. Oh, phew. Helping people when they have those self-hating cognitions. I say, when you say those words, it was my fault. I am so stupid. Do you feel better or do you feel worse? Believe it or not, many of our clients who ruminate every day about fault, worthlessness, stupidity, they don't notice that each time they have the thought, they feel worse, right? That takes mindfulness. You know, in mindfulness, in the meditation world, I should say, meditators are encouraged to notice with interest whatever comes to mind and to notice without attachment or aversion. That's the language of meditation. And it's such a great concept because it's true. Most of us have a tendency to believe some of our thoughts and avoid or argue with or push away other thoughts. The same with feelings, right? You know, think about all the people you know, this is not just clients, who say, well, I don't cry. Right? And as opposed to, I'm thinking of my goddaughter who says, I'm a crier. Hey, just face it, everybody. I'm a crier. I'm going to cry when there's sad occasions. I'm going to cry when there are happy occasions, right? So she attaches to her sad feelings. And we all do. Some people attach to their angry feelings. Some people avoid angry feelings. For our clients, that can be dangerous because often they attach to beliefs like, I'm worthless, it's my fault, I don't deserve anything. And they have an aversion to self-compassion or an aversion to sadness. And so when we teach clients to be mindful, we're encouraging them to be curious about all thoughts and feelings rather than biased towards some and hostile toward others. Just, you know, to me, just in the last few months, a number of clients, I think because they're doing better and they're having more positive feelings, they have said, you know, don't be so positive. It's very triggering for me when somebody gives me a compliment or says I'm doing well. Some of them are also triggered by any good feeling, even if it's self-generated as opposed to interpersonal. And again, we have to use mindfulness to bring awareness to these tendencies. I have a long-term client I call Annie. Annie has complained forever, as long as I've known her, about how unhappy she is. It was a revolution to realize and to notice that any time she had a happy feeling, it was cut off by negative thoughts. And then it was no longer, oh, I'm so unhappy. I've had so much therapy and I'm still unhappy. She could notice how her mind and body really fought positive feelings. Now, I'm just looking at the time here. Okay, we're doing well. I want to say a little bit about mindfulness and neuroplasticity, which is an idea that came originally from Dan Siegel. Right? When we began to have the ability to study living human brains using brain scan technology, we learned about things that no brain scientist had ever known about. We learned something very nice for us older folks, that brain cells can grow, brain structures can grow and change throughout the lifespan. So rather than thinking, oh, I'm getting older and my brain cells are rotting away, we now know that with continued use, we keep our brains well exercised, that they keep changing in a positive direction. The research shows that it's called neuroplastic change, meaning change in the neurons and neuron systems in the brain, at any age, can improve stress response, affect tolerance, and even immune function. Right? So use those brains. Luckily, in our line of work, that's easy to do. And neuroplasticity works two ways. We can create new connections and new networks of connections. The brain can also delete old connections. And this is called pruning. And we're not taking pruning shears and snipping away. It's simply that underutilized neural connections gradually fade away. And more importantly, the neural pathways that are frequently stimulated become more and more strengthened and more easily stimulated. It's the use it or lose it idea. Use it and improve it, or don't use it and lose it. Now, very, very important, because our clients tend to use the same words and the same ideas and have the same feelings over and over and over again every day, which is a factor of their trauma, and how it shaped their brains. So the principle, we don't have to know a lot about the brain or neuroplasticity to take advantage of it, because neuroplasticity, changes in brain, can be induced simply by changing the amount and kind of sensory stimulation reaching the brain. So in your setting, what kinds of stimulation is the client's brain getting now? Does that stimulation reinforce trauma-related patterns, or does it challenge them? And how do we change what kind of sensory stimulation reaches the brain? Good question. The second principle is that neuroplasticity has to be directed, meaning it has to be consistent. To change the brain, we have to ask the client to repeat over and over again new patterns until they become neural networks. That requires us to be willing to be that repetitive, and probably requires that we educate the client a little bit about, we have to find some new words for you, because when you use the same words over and over, your brain thinks that they're true. And you don't want your brain to agree with you that you know, you'll never be worthy of having a good life. Dan Siegel also emphasizes that neuroplasticity requires mindfulness because focus and concentration stimulate neural firing, which, and if we're focused, it's like using the focus of attention like a laser, right? So we keep laser focused on the patterns we wish to help the clients restructure. To do that requires that we get the client to be interested in this idea that they could change their brains. Now, here we have a problem. We are required to assess suicidality and other risks. And so we have to focus on suicide. But the more we focus on suicide, the more we're going to stimulate the neural networks that are associated with the idea, when I feel bad, I should die. And so we're kind of between a rock and a hard place here. The more we engage in talking about suicide as if it were an alternative, the more time we give the client to talk about the 20 reasons why they should be dead, we're actually stimulating the neural networks that we don't want to stimulate. Every time we interrupt a client and disrupt that pattern, I do it by saying, when the client says, I want to die or I'm going to kill myself, I say, and is that a thought, a feeling, or a physical sensation? Because if I disrupt the thought, it gives the client a chance. Well, first of all, it gives them a chance not to sensitize that neural network again and again, but it also gives them the opportunity to grow other areas of the brain. Don't be afraid to be repetitive. I probably repeat myself all day long. Sometimes it's a little horrifying to think that I've gone through an entire day just saying, notice that, notice that, notice that. I also don't hesitate to help clients find different words, because a client, so I might ask the client, so you have this thought, I want to die. And do you also have, what thought do you have about being in the hospital? And the client usually says, I don't want to be in the hospital. Say, okay. So there's a little conflict between these thoughts. One thought is, I want to die. The other thought is, I don't want to be in the hospital. So maybe we should focus on how to stay out of the hospital, even though you have thoughts of wanting to die. What happens, right? When you think about dying, what is it that you're hoping for? And of course, you know what the clients will say. The client says relief. And I say, okay. So what happens if you say the words, I want relief? And most of the time, clients will say, I do want relief. I want relief. And I say, does that feel better or worse when you say, I want relief? Most people say it feels better. And I say, okay, so what happens if you say, I want relief? Are there any impulses that go with it? And most clients say, no, I just want relief. So, as soon as we get the impulse out of it, the client is safe. Nobody ever died through longing to die. People die because they have suicidal ideation that then stimulates impulses. So it takes the idea and the impulse and the action to become a threat to life. Another very important mindfulness skill for our clients is what is called in sensory motor psychotherapy, dropping the content. It's a technique for letting go of distressing thoughts and feelings. Again, so that those, what I'll call dangerous, unsafe neural networks don't keep getting stimulated. Often for clients, it's very helpful to learn to drop the content and then focus on something very concrete, like the feeling of their feet on the floor. And it's simple, and most clients can do it. So I'll show you, I'll show you how I do it. I ask the client, I don't ask the client, actually, I put out my hand like this, so palm up. And I say, imagine someone putting a burning hot baked potato in this hand. What's this hand going to do? And everybody goes like that. I mean, it's interesting. I never ask the client to put out their hand. Most clients do. They just imitate me. And even if they don't put out their hand, as soon as I say, imagine this burning hot baked potato in the hand, even if they haven't put out their hands, I can see their hands doing this. And I say, okay, this is what you're going to do with all those negative thoughts, right? You're going to drop them like a hot potato. And so then I have to follow it up, because 5 minutes later, the client could say, it's all because I'm so stupid. And I say, drop it. So I practice it, whether you work in a residential hospital or clinic setting, there will be so many opportunities to help clients to develop this skill, because it's a lifesaver. So, somehow I don't know why I had. Sorry. So we seem to have the same slides. All right, here's the directions for dropping the content. I think I finished these slides too late at night. I ended up duplicating my own material. So what does this all mean for us? It means thinking about the brains of our clients, not just their safety, not just their emotional lives. Because if we think about the brain and how to make use of it, they will be safer. I often say that if you have a working prefrontal cortex, you are not going to harm yourself. Right? Dangerous, unsafe, impulsive behavior occurs when the prefrontal cortex is shut down. We have to remember that the brain science has taught us that therapeutic focus on unresolved feelings, thoughts, memories, or behavior can reinforce the neural circuits holding them. And that's very, very important because that's the last thing we want to do. We've also been taught to believe that we are not supposed to interrupt clients when they're expressing themselves. But actually, when we disrupt a negative pattern of thoughts or feelings or behavior, we actually create an opportunity to increase activity in some other part of the brain. You can disrupt a negative pattern with lightness and humor. And so clients don't feel interrupted. They don't feel unheard. They, oftentimes they don't know that I would say most of the time, they don't know I'm disrupting them. Because if I interrupt with humor, with empathy, with lightness, it doesn't feel dismissive. Oops. So the therapeutic benefits of mindfulness are many. And again, we're talking across diagnoses, right? Even if the client's trauma is not in the forefront of treatment, as it will not be with many clients diagnosed with schizophrenia, with depression, even with borderline personality disorder, because we often forget that borderline personality is a trauma-related disorder. So whatever the diagnosis, mindfulness has these benefits, right? Increases the activity in the medial prefrontal cortex and therefore reduces activity in the amygdala. So it regulates arousal, which means the hyper-aroused clients settle, the hypo-aroused clients have a tad more energy. Studies have shown that mindfulness results in more benign stress appraisals, right? A tendency to interpret cause and effect more accurately rather than in a way biased by the trauma. Reduced avoidance as a way of coping. Wouldn't that be nice? We all would appreciate that. An increased sense of well-being. And there are studies that show reduced PTSD symptoms when mindfulness is used in the treatment. So I just want to end with this emphasis on repetition. Took many repetitions for our clients to develop the patterns they have. And it will take many repetitions to change those. So these are the words of Thoreau. As a single footstep will not make a path on the earth, so a single thought will not make a pathway in the mind. To make a deep physical path, we walk again and again. To make a deep mental path, we must think over and over the kinds of thoughts we wish to dominate our lives. So we have plenty of time for questions and cases and whatever else. Let's see, I'm just looking at the chat to see if there were any questions. Anybody have any questions about
I do have a question,
Yeah,
Ms.
yeah.
Fisher. At the Center for Mindfulness, the UMass Center for Mindfulness, they used all kinds of techniques like mindful walking, yoga, and so on and so forth. Are there any statistics that you know of that incorporate those kinds of things and show any difference that they make with patients?
Well, I think the mindful piece is the important piece because the research on the benefits of mindfulness is substantial. And I don't see why that couldn't apply to mindful walking and mindful yoga. I mean, yoga in and of itself is mindful. And certainly for people who are tormented mentally, it's great when we can get them in their bodies doing something non-destructive. Yeah. Any other questions?
Dr. Fisher, we had a comment in the chat. Joel asks, do you have examples of your humor to disrupt a thought?
Well, yes, I can give you some. So the client says, the client is perseverating on, I'm worthless, it's hopeless, and thoughts like that. And I say, yeah, doesn't it suck? When you have those thoughts, doesn't it suck? And then they laugh, right? Because when we use traditional empathy, it must be hard for you to feel that way. We actually encourage the client to tell us more about their painful negative thoughts. Sometimes I say, oh my God, these thoughts are killing you. These thoughts are like rat poison. They are slowly killing you. And so the next time they say the same thought, I can say, oh my God, this is toxic. This is really dangerous to your health, all this rat poison you're taking in. So they're usually a little shocked. If you're willing to be a little outrageous, still professional, but a little quirky, a little crazy, it definitely gets people out of their kind of little bubble of shame or hopelessness or self-hatred. This is a question that came through the chat. I was curious about what kinds of changes to milieu settings could be made to address your suggestion that stimulation in the setting should be other than a reminder of the trauma or of the negative aspects of the client's life. There's so many things. I actually trained hospital staff in Norway on two units of a large hospital. I trained the staff in mindful communication with clients, and so it really changed the flavor of the conversation to use mindfulness. So if the client began talking about the trauma or the past, we would respond to it mindfully, right? When you talk about that, what happens inside you now? Because again, the mindfulness is going to calm the feelings and and sensations. Doing suicide assessments, I think that's a little trickier. But I'm thinking, if you do a full suicide assessment questionnaire with every client, every time you meet, which in some, I don't know if is that true in DMH settings. I think in the state of Connecticut where I did a lot of consulting and teaching like this, the therapists and staff all had to do like a complete suicide interview at every session. And so that's a lot of stimulation of the suicidal ideation. And I think we can figure out ways around that. So for example, if the client, if the client says, I wish I were dead, that's suicidal ideation, right? And suicidal ideation never hurt anybody. And so I think our suicide assessments have to focus less on thoughts and more on impulses. So what I do is I use a 0 to 10 scale for how much the client wants to die. So I say, on a 0 to 10 scale, how much do you wish you could die? And then I ask, and on a 0 to 10 scale, how impulsive do you feel? Because it's only dangerous to have suicidal ideation with impulsivity. It's not dangerous to lie in your bed and wish you were dead. It alarms us because we worry that those thoughts will lead to impulses. But most people tend to have, I would say the majority of trauma patients have passive suicidal thoughts. We tend to see the smaller percentages that have active suicidal thoughts, meaning they're very high on the impulsivity scale. And that's really what we have to bring down. Mindfulness, again, is very, very helpful for that. Do you find that there are questions on the suicide assessments that are most useful in assessing how safe or unsafe the client is? Because I think if we could reduce the number of questions to a smaller number, so we have more of a quick safety check-in, that would be a good compromise between stimulating more I want to die thoughts, which we certainly don't want to do. And then I think giving people alternatives, like teaching them to say, I want relief. So that there's a difference, there's an impulse to kill yourself, and there's a wish for relief, and the two are different. Many of my suicidal clients have said, in retrospect, after years of hospitalizations and attempts, they've said, I never really wanted to kill myself. I just wanted to not feel the way I was feeling. But the more they talked about wanting to die, the more impulsive they became. So that's our challenge. How do we help people acknowledge their risk without
No, I muted it.
Yeah. So did you have a question, Monica?
No, sorry.
That's great. I mean, how do you all feel about the effectiveness of DBT with your clients? You look underwhelmed.
Well, Janina, I'll jump in from a few steps away. And as someone who gets kind of the daily acuity reports, I see that there are youth within certain programs who are constantly in a high state of acuity. So I'm thinking mindfulness is so fleeting and rest is so limited. I see almost a pattern of which there's continual kindling, there's continual neural excitement, there's limited mindfulness, slowing, and I'm wondering about, I love the idea of the hot potato and dropping it, and would love to have something like that for these youth who are so hardwired for high acuity and with that lethality and harmfulness to staff. So loving the idea of other interventions, or even the language that you use, that sucks, because I think that language is attention getting. So things that can disrupt, distract, shift enough, but how to piece it together so we get a full day of quiescence would be a wonderful thing, because there are colleagues who walk this walk every single day, God bless them, but it's painful and it's hard. So how to get mindfulness when somebody's unable to settle. And it also transmits to the staff as well. It kind of collects
Absolutely.
the contagion with the other youth, the other staff. So how to interject, milieu-based mindfulness.
Right.
There's not much to spare.
Right. Well, it's so hard because teenagers are so impulsive anyway. Like normal. No, I mean, I'm remembering my children when they were teenagers. They were a hot mess. So, you add trauma to that, and it's really rough. Because they have lots of activation and very few ways of managing the activation. So probably in a milieu setting, I would teach everybody the window of tolerance diagram, the hyper and hyperarousal diagram, and ask them for sort of nervous system checks. Okay, how's everybody's nervous system doing? Right. How many people are up here? How many are down in the window of tolerance? How many are in the hypo zone? And helping them to, it's harder to get teenagers to notice their impulsivity. It's easier to get them to notice their nervous system ratcheting up. Because of course, they're busy saying, no, I'm not going to do anything. Right. They're not good at saying, yes, I'm feeling impulsive. Because I think that feels like admitting something bad. So, the more in milieu settings, the more we ask teenagers to notice and help them police each other. So that there's less non-mindful talk. That would definitely help. and I find teenagers love psychoeducation. They may not remember it when they're triggered and their frontal lobes are offline, but at least it can help them focus in the right direction. Right. So that's interesting. Julie says it's hard to assess how effective DBT is because there may be DBT groups, but that doesn't mean that DBT is used consistently throughout the program. And yes, that's a really good point. And also, the biggest difficulty I have with DBT is that it takes a lot of thinking, right? Because it requires these teenagers to think, okay, what's my distraction technique? Which distraction technique do I want to use? Which is not where the adolescent brain usually goes. And so it's really, I think it's really challenging to figure out how to bring DBT into the milieu and make it part of the conversation and make it simpler, because DBT is a little complicated for people whose brains are not working. So Kurt Woodring says, my experience and the research indicates that discussing suicide does not have an iatrogenic effect, which it seems you are suggesting. Individuals who are suicidal often find relief from having an opportunity to openly discuss their thoughts, feelings, and impulses and not be judged. Absolutely, I couldn't agree more. Opening up that avenue can help decrease risk. I think that's true, and it's complicated. I have known so many suicidal clients who get revved up the more they talk about suicide. And so I think the wonderful thing about Kirk bringing up this point is that we have to, we can't be programmatic. We have to notice, does talking about wanting to die rev up the client more and lead to more ideas for how to do it? Or is this a client who needs to express expressing the ideation leads to relief? It's really I think the clients who spend endless hours thinking of all the reasons they should die. I think those are the clients who are more at risk. Anybody want to add to that idea? Because I think it's a really, really good point that Kirk is making. Okay, well, I noticed that we're just about out of time. And Dana has put your survey in the chat box. Thank you guys so much for coming today. And
thank you, Janina. This was awesome.
Take care. Keep doing the wonderful work that you're doing.